So group 4, chronic thromboembolic disease, PH, so-called Cte Ph, is a very challenging area in my opinion, because it's difficult to understand exactly why a patient goes on to develop chronic thromboembolic disease, pulmonary hypertension. The experience would suggest that the patient probably had a blood clot in the legs, in the venous circulation in the legs, that dislodged and ended up in the pulmonary circulation, what's referred to as a pulmonary embolus. And if that's diagnosed and treated with blood thinner, 99% plus the time, the clot in the leg and the clot in the lung completely resolve without any long-term injury to the pulmonary circulation. But in about 1%, maybe a little less, that does not happen. And the clot in the lung gets replaced with a cellular material that's adherent to the lining of the inside of the pulmonary arteries and blocks blood flow, narrows the blood vessels. And that's referred to as the chronic thromboembolism that can be detected with imaging studies. And those patients, of course, because of the narrowing, have a high resistance to the blood flow. The heart has to generate a higher pressure to overcome that resistance. And that is pulmonary hypertension, and it's in association with chronic thromboembolism, so hence the name chronic thromboembolic pulmonary hypertension. As you sort of work backwards from the diagnosis through the patient's history, there have been efforts to identify patients that might be at more risk for chronic thromboembolic disease, pulmonary hypertension. If they had a really large pulmonary embolus and there was effect on the heart from that large pulmonary embolus at the time of the acute event, that patient might be at a little higher risk. But again, the overwhelming majority of even those patients have full recovery just with blood thinner. Secondly, there may be patients who have blood clots and never know it. And why might that occur? Well, I don't want to cause any more anxiety than there is currently in our country. But if you're sedentary for a long period of time on a long car ride or a long plane ride, for example, the circulation in the legs is also sedentary. So you might develop a clot in the legs and never really know it. Maybe there was a little swelling and you got up and about later and you were fine. Or maybe there was a tiny clot that broke off and went to the lung, but it wasn't very symptomatic. So there could be patients that have what we call subclinical venous thromboembolism that go on to develop chronic thromboembolic disease. Why would I even raise that as a possibility? It's because 25 to 45% of the patients don't have a previous diagnosis of a venous clot in the legs or a pulmonary embolus. So obviously, if the initial cause of Cte Ph was a blood clot and the patient never knew it, it was asymptomatic or subclinical, and therefore you can be surprised at times that patients even without this history have Cte Ph. And that's why it's very important to emphasize that in patients that are diagnosed with pulmonary hypertension, that all patients have a screening test for Cte Ph. The screening test that's recommended based on the guidelines is a ventilation perfusion lung scan, a VQ scan. If that's positive, then you need to do additional testing because those patients may have a chance for a curative surgery, what's called a pulmonary thromboendarterectomy, or be eligible for specific therapy with real SIGWAT. Very important subgroup to identify. If all of this overwhelms you as a provider, you need to refer the patient to a pulmonary hypertension center where they have expertise. We have a multidisciplinary group that includes pulmonology, cardiology, critical care doctors, special radiologists who just look at these types of imaging studies, cardiothoracic surgery, etc., who review all these cases to determine the diagnosis and the best treatment. Very important to have that expertise because it can be very subtle, and it's very important to make a correct diagnosis in order to make the correct treatment recommendations.
So there are various comorbidities and risk factors for chronic thromboembolic pulmonary hypertension. These include chronic inflammatory disorders, chronic infections such as infected pacemaker leads, patients who have ventricular atrial shunts, have a prior splenectomy, or patients with antiphospholipid antibody syndrome or lupus anticoagulant. Additionally, malignancy is a risk factor for chronic thromboembolic pulmonary hypertension as well, and is an important comorbidity in patients with CTEPH. Compared to idiopathic pulmonary arterial hypertension, patients with CTEPH tend to have more comorbidities, and this can impact perioperative risk stratification and eligibility for procedures such as pulmonary thromboendarterectomy.